Coming up on the Unmasking Minds, Empowering Mental Health Conversations podcast.
Mentally, we have to feel like, I want this pain out of me and out of my child.
Denial is hard to accept, especially when it comes to your kids.
Some of these parents have been traumatized. And some of these parents have a history of being ridiculed and put down and black sheeps. So when they start to observe their children having problems, they may kind of hide it.
Today, we'll dive deeper into denial some parents have when it comes to their kids' mental health.
Some parents are afraid therapy equals medication. Some parents are afraid therapy equals my child is going to be locked away in a room in a padded room. So a lot of that is misinformation.
A tough topic to unpack, but we'll do it coming up on the podcast. So come on over to the set and let's have this intimate conversation on the Unmasking Minds. Hey y'all, what's up? It's your boy Anthony Redmond, also known as the Doc. Welcome to the Unmasking Minds, Empowering Mental Health Conversations podcast, the show where we are aiming to break the stigma surrounding mental health. And we want everyone involved in the conversation, because if we all work together to help tackle this problem, we'll be able to inspire change. Before we hop into today's show, I want to start by saying us as parents, we make mistakes and sometimes we need guidance too, especially when it comes to our kids' mental health. Some parents may be in denial and some may not even acknowledge that their kids are struggling mentally. To help us navigate this conversation, I am joined by the therapist, Robert Mitchell, who has over 25 years of experience. Robert, thank you for coming. I appreciate you being here with me. I reached out to you and you said, yes, I would do this show. We both know this show is very touchy, so please introduce yourself to the viewers.
Absolutely. Hello, everyone. I'm Robert Mitchell. I'm a social worker. I've been working with children and families since 1998 in various capacities. I worked in a residential group home on the floor with children, watching them go through different emotional and behavioral challenges. I also work for the state of Michigan in the foster care division. I've been there for like 15 years. I do community outreach programs, and I too was an at-risk youth, and I'm sure there was some mental health, emotional challenges that I was experiencing during that time that, you know, when I was a kid, we didn't go get diagnosed for things. We were just, you know, hey, go play some basketball, things of that nature. So yeah, I've been working with kids and I really love it because I saw something a long time ago by a famous person named, I think it was by Malcolm X, and he talked about children being a catalyst for change. So I began targeting children because I wanted to see a better world.
I like that. I like that. So I'm going to share with the viewers how I see you, okay? You forgot to mention that you work at my private practice.
Oh, yes.
And we did some wonderful, powerful work. Yes. Let me, viewers, you don't know this. I think very highly of this guy because when he came to my private practice, Mr. Mitchell here, he came from a dialectical aspect of treatment, helping people. And I was trained with cognitive behavioral treatment aspect. And we debated constantly. You remember? We debated and I said, okay, Robert's not giving up. Let me dive into this dialectical behavioral treatment process. And as I started to read and watch videos and I went to several training courses, and wow, it was eye-opening. Not for me helping other people, but also that what I practice for myself to help me dealing with strong emotions. Yes. So I commend you. I'm happy that you challenged me, and I'm happy that you're here because only a few guys I would sit down and actually have some deep conversations with. And I told you several times, you my go-to person. So when I like to spar, I call it spar on some deep dialectical, deep mental health issues, I always call you.
Thank you. Thank you.
So thank you for coming here. And you know, this topic is very sensitive because parents, you have all this experience with adolescents and youth, and children. What do you see? What do you see that parents are doing that is causing major problems to their children?
I want to go back to DBT and then tie this into this conversation. Okay. I got into DBT. I was reading up about Eastern philosophy, and there's a guy named Mao Zedong, and he had this book, and it talked about dialectical thinking. And part of it was the unity of opposites. And I was drawn by that because I felt like oftentimes we have differences with people and we view it as an opposing position when it's merely just another aspect of a position. So I said, wow, I can use that because I really want to be able to reach and help people and not be stuck in these differences. Now, that was a tool that I began using working in the group home setting with children who were very upset and angry and felt abandoned. And I watched this one guy, and he was so calm, and he would listen before responding. And I wanted to be like this guy. His name is Michael Petty. He was so calm. So I started studying guys like Tim Duncan, Akeem Olajuwon, DBT, people who had composure, who I felt took the time to be present with the other individual. That is what is a major tool in getting parents to buy in to mental health treatment for their children. Because a lot of the times we're dealing with internal and external challenges that the parents may have. Internally, how you think is how you feel. So many of our behaviors are based on lack of information and fear. Fear of what will happen if my child was to be diagnosed. Is that going to reinforce a stigma? Is that going to make me feel bad about myself? Some of these parents have been traumatized. And some of these parents have a history of being ridiculed and put down and black sheeps. So when they start to observe their children having problems, they may kind of hide it and start covering it up. And it festers and it festers. And then it gets to a point where it's quite obvious that this isn't working. And they might even say, well, you know what? I'm a little open to trying this out. But getting them to remain in therapy is also a challenge because the child may be reluctant and may be able to convince the parent that this is not working. And we're just, I mean, it's so many layers. I think another fear is medication. Some parents are afraid therapy equals medication. Some parents are afraid therapy equals my child is going to be locked away in a room in a padded room. So a lot of that is misinformation. And for certain cultures, they have certain traditions and expectations when it comes to therapy. Some cultures are like, you know, this is something we handle amongst ourselves. Some cultures are more willing to have a therapist that mirrors them. So a black person may want a black therapist. Right. A woman may want a woman, et cetera, et cetera, et cetera. Right. But these are barriers because I look at it like this. Physically, if you went to the doctor and you were in a painful situation, you're not going to say, hey, hold on, I don't want this surgery unless it's being done by this particular or that particular practitioner. Right. But when it comes to mental health, for some reason, we don't look at it as severe. Physically, we can feel the pain. We know I want this pain out of me. Yes. But mentally, we have to feel like I want this pain out of me and out of my child. So sometimes if you don't have that experience or you're not aware of the fact that you do have a mental health challenge, that because a lot of it is hereditary. And in our culture, in many other cultures, we find ways to kind of sweep that under the rug and say, oh, he just fine. He been eating too much sugar.
You know, I like this. Wait a minute, because my favorite saying, I think you know this, the apple does not fall too far from that tree.
Absolutely.
So if you see mental health in a child, usually you got to look into the family dynamics, because it's somewhere in that family that apple is laying there too.
Absolutely.
You get me what I'm saying?
Yes.
So go ahead.
Social learning theory, Alpha Bandura.
Social learning theory.
Narrative therapy. There are narratives that have been passed down from the culture, and that's where the stigmas come. You know, African American people have been stigmatized as being slow, as being incompetent, incapable. And if you don't have the resiliency or the people around you to help you deal with that perception, when you begin to feel like you're lacking in some area, you may not know who to run to or be comfortable enough to run to someone. Because once again, you know, you don't want to feel like you're stupid or you're crazy, not knowing that all of these diagnoses exist in all humans because we are all Homo sapiens. We're not eagles. We're not giraffes. We're not butterflies. We are Homo sapiens. Every behavior that exists in all humans. Everything that you could think of. So it's more normal than abnormal. Abnormal is normal. It's just to what degree is this thing that we call abnormal. And some of that is relative and situational. A kid who's ADHD in this setting may be very creative and imaginative, and in another setting that is able to stimulate them. So sometimes children are misdiagnosed, and that's another fear that parents have. Some parents may feel like, I don't necessarily think my child is slow, per se. They may, because here's the thing. What are the markers? So when I worked in a group home setting, we had children who were, and this is socially and culturally, who were funny, who could play sports, who were handsome. Mm-hmm. So these are the markers. Right. So once you feel the markers, you're not really looked at as having a shortcoming. And then you can get what? From the school setting, socially promoted. Socially promoted. And so when you come to the parent and you say, well, yeah, when a teacher's brave enough to say, I don't want to socially promote this child. Now they have to go butt up against the administration and the parents themselves.
Okay, let me jump in there. I'm glad you brought this up, because this is my domain. Teachers don't know. Mm. They just see a kid performing low. But they don't understand the impact of what's really going on with this child. And teachers, I'm sorry teachers, don't get mad at me. Please don't. They mislabel children. Mm. And it drives me nuts. Because they are saying, he's ODD, oppositional defiant disorder. I'm like, well, how do you know? I don't even know. We don't know until we test it. The Connors, right? We don't know until we test the children. Mm. This child exhibiting, maybe it's trauma. Maybe daddy didn't come home. Maybe they don't have food in the house. You cannot label children until they go through the proper procedure with the proper diagnosis. Mm. Go ahead.
What's the barrier to that?
Barrier.
Why aren't our children being diagnosed? Would it have? Well,
okay. School diagnosis is different from clinical. Okay. So school diagnosis more comes from how this kid is, how this issue is impacting their academic performance. Yes. I'm trying to talk to make sure that people understand what we're talking about. Absolutely. So I'm looking for words, right? I was going to say a word that I'm like, well, they won't know that word. So what happened is this. I look at a child, the child performing very low in a school setting. So when we come to a child study team meeting, some schools call it something different, but we used to call it child study team meetings. And it's the teacher, it's the school psychologist, school social worker, the principal, the parents. Now you think about the parents now. They sit in front of all these professional people. They in denial. They trying to hurt my child. This is not true. I know little Johnny, or I know little Mikey. No, this child is this way at home, and you guys are lying on my child. And I understand, because we both are parents. That's my child. You don't want that label on your child, but parents, allow the school system to do their work. Allow the mental health providers to do the right necessary assessments to come up with this diagnosis so we can help your child.
I tell the parents in foster care, I'll say, look, okay, here it is. I'm in your life for maybe 9 months to a year, year and a half at most, hopefully, right? At the end of the day, you could walk away with some information that could be helpful. Now, it may not be helpful today, tomorrow, next week, but when you start to see some of these symptoms, if you read this report, it can trigger that thought back into your mind to say, you know what? This is the same thing that was on this report. He's exhibiting or she is exhibiting the same behavior. So it could be a tool. But, sometimes my uncle says you have to wait for the window of opportunity to open up. So sometimes the window of opportunity hasn't opened for someone to be willing to explore, engage, and commit to mental health care for their children.
So a question, how can a parent's interference or denial impacts that child directly?
It could be a negative reinforcement because now the child is not getting the help that they need. They're continuing to engage in the same behaviors. They may be in a classroom. Let's say they have ADHD, which, some people feel like, oh, that's a made up diagnosis. But let's just say it's actually true. After we've tested in the different settings, inconclusively, it's showing that this person is having difficulty just staying focused. So now that the kid can't really focus, they're getting behind in class. So now they're horse playing. They're horse playing, now they're getting kicked out of school. They're getting kicked out of school, now they're engaging in risque behaviors. They're engaging in risque behaviors, and now they're in juvenile. They're in juvenile, they get out, now they're using, it just becomes a snowball effect because they're not getting the help that they need. And now they're still engaging in the same behavior, not sitting still in the class, disrupting the classroom setting, putting their hands on other people. And those same behaviors at some point lead to other unsettling behaviors.
Okay, I'm gonna throw this at you. A child is very quiet, teen, like between 12 and 15. Okay. But suicidal ideation, they writing letters, they saying nobody likes them, they don't want to be around them, want to play with them, and they just want to die. And the parents are in complete denial about this. What's your take on that?
I think it's a fear. I think some of the times it's like, if you're scared of something, fight or flight response. It's a flight response. The parent doesn't want to face the fear of their child actually hurting themselves. So they just ignore it. If you close your eyes, it don't exist.
And the sad thing, let's look at the risk now to that child. Now, it's a child. That child, and I'm talking because this is very dear to my heart, okay? I have seen this so many times coming in my office, and we both have seen this, that it's a child. And this child has all these feelings. Suicidal. I take that very serious. Suicidal is more about to be moderate to severe mental health issue. You at that point, something is really going on. That's almost like hospitalization. You know, you got mild, moderate, severe mental health. And I take suicidal ideation, constantly writing letters on it. That's more moderate to severe now. We need to get this child some help. And the parents, nah, I'll talk to him, or I'll talk to her, or they cutting, right? They seeking help. The parents are so in denial, and we are sitting down working with this kid, and the parents are in total denial. Do you get angry?
Denial is what? It's a defense mechanism.
Defense mechanism. You're absolutely right.
It's a defense mechanism.
But why? But why are parents doing this?
It's one of their biggest fears. A parent's biggest fear is to lose their child.
But
I think that's part of it. I'm not saying it's right.
Right. But denying the situation, you're going to actually lose your child.
I think in their mind, since it hasn't happened, I think a lot of things that we don't fully understand, we operate in the concrete versus the abstract.
Break that down, because I don't think they understand that, Robert. I do.
So I have asthma.
Okay.
It's a hidden disability. So I wear a scarf, and my buddy might laugh at me, or I might be coughing and we're in a car. They don't have the sensitivity towards it because it's not something that resonates as concrete. But if I had a cast on my leg and I was walking through the door, they would be kind enough to open the door for me because they can tangibly see this challenge that I'm facing. Mm-hmm. So when it comes to suicide, the person still hasn't killed themselves. Now, I think it'd be a little different if they see them in a pool of blood or something like that. But I mean, I think when you start cutting, that is a pretty intense sign. But depending on how much you don't want to face this, like domestic violence, you can just keep saying, well, he just hit me. Well, she just did that. Well, you can just keep minimize. These are all defense mechanisms. And some of it is culturally embedded because, some cultures are in denial. They want to earmark certain disabilities or mental health disorders as belonging to this group of people. We don't do that. We don't kill ourselves. That's not something we do. Or sometimes gender could play a factor in that. As men, we've been told we don't cry. We don't harm ourselves. We are strong. Boy, just strengthen up. And we think if we just help them strengthen up, and we don't understand the fragility at that moment.
Robert, that's deep. And when you say that, I share with my viewers that my dad died at 16, and you know this story. I was suicidal. My pops and my uncles and my older brothers, man up. And his funeral, my dad didn't like tears. So at his funeral, I'm sitting there numb. I wanted to cry, but I'm looking at him like, man up. Tears don't save the day. So I suppress. I'm 16, 17, 18. And I'm playing football in college now. And I broke down. I couldn't take it no more. I couldn't, I was grieving for that long. And I didn't know what was wrong with me. I went to my mom. I remember my senior year in high school, I went to my mom, like, Mom, something wrong with me. She was like, you just bad.
Back to that again, right? Back to sugar.
I'm acting out. I'm snapping at teachers.
You was eating too much sugar.
I'm snapping at teachers. I used to be like a little jokester in the school to checking teachers. But that was that depression. It was depression. I was angry. I was frustrated. I was irritated very easily, symptoms of grief and depression, right? I didn't know that at 16, 17 years old. I didn't know nothing about depression. I learned about depression when I started studying psychology. And back in the day, we had the encyclopedia. We didn't have Google search. We had to go to the encyclopedia or to the microfiles inside the library. Like, these kids don't understand how easy they have it right now, right? And research what is depression? What is grief? Whoa, that's me.
Yes.
Right? So as a child, 16 teenager, I went to my mom. I wanted to kill myself because I wanted that pain to go away. You see what I'm saying? I can't speak for other people, but I wanted that grief, that pain. My father's gone, man. He was my hero. He's gone. What do I do now with my life? I didn't want to live anymore. I didn't have no one to talk to. I was here. And I knew what was wrong with me. I want that pain to go away. So for my mom, I'm not going, Mom, please, if you watch this, I'm sorry, don't cry. I love you. It's not like you knew what to do. She didn't know what to do. You know, they're from Mississippi. And you know the southern states, you know, it's different from the northern states, right? More resource in the north. And people going to see Mississippi like, no, it's not. But it is. Let's just be real, right? So she didn't know. She did the best she knew how. And in her days growing up, they didn't even talk about mental health. Pray it off. They're going to be another podcast show.
Pray it off.
We're gonna talk about religion and mental health. We not in a black community.
Yeah.
We're not gonna talk about it here. We focus on parents in denial of their children's mental health. And they're sitting there not doing anything.
Religion plays a part in it, though, too. Yeah. Some people believe that they can pray away mental health or go to the pastor, and that's not to say that those two tools don't work. I'm not here to refute it or advocate for it.
Right.
I think it's a tool.
It's a tool.
But just like a carpenter has a hammer, screwdriver, nail gun,
tape measure.
yeah, and,
Right.
yeah, and we got to get people to kind of buy into using more tools.
Do you know why parents, you said fear, parents deny what's really going on? Pretty much you said fear, right?
That's number one, fear. But I always grapple with this. Mm-hmm. It's two things that gravely impact human behavior in my estimation. Fear and ignorance. I mean, aside from the biological, chemical, neural, that's another thing. But fear, and let me use another word, lack of knowledge.
Lack of knowledge. Let me go even deeper. Social economic status.
That definitely impacts it. It impacts all of those spheres.
A have and a have nots.
Yeah.
And it's sad.
And that's why we're here.
And you know, we both work hard. And you saw, you know, our caseloads. We on Saturdays, Sundays, I work 7 days a week. I can't do it anymore. I want to help everybody, but I can't do it. And I think this right here, and you being on this podcast show, and we are talking about these issues, I'm hoping that we could touch many people to go get help. Because in the future, as I told you, my angle of this podcast show is to attach it to my mental health foundation so I could get more people to help. I could expand myself in a way through social media that I could give the help without really leaving my home.
Absolutely. Yeah, there's so many tools that you have, we have, you know, at our disposal. I mean, there's things online. There's so much stuff we can break down that could be useful. Just, you know, you just have to be able to open.
How can mental health professionals and other individuals involved in their child's treatment teamwork together to address parental denial and interference?
Just like a multidisciplinary team. We have to come together as a team, look at what we bring to the table, and then assess, do assessment. Assess what the problem is, discuss what we see as the challenges and the barriers, and look at what resources and skills we have that we can access, and then put it on the flow, as the rapper says.
Right. Put it on, right? So are there any specific legal or ethical considerations that need to be taken into account when parental, you know, neglecting?
Yeah, like in foster care, for example, when the children are in foster care, their rights have not been terminated. So the parents can still decide whether or not they want their children to have medication. They have to sign consent. That's a legal consideration right there. Then we have cultural considerations, like Native Americans. I mean, there's certain rights that they have as well, and then certain cultures, and maybe this isn't legal what I'm speaking to. I think that's more ethical, the ethical boundaries of different populations and how to navigate amidst all of that.
Let's talk about the social welfare laws. Let's go back to the best interest of the child. And a parent's neglecting. Now, I'm coming from a school perspective at this point, that when I was a former school psychologist and school social worker, kids were missing 50, 60, 70 days from school. That's you're neglecting that child.
Yes.
And we used to hold parents to I used to hold parents to high standards. And a lot of my administrators, they was upset with me. I couldn't work in a school setting because they were sugarcoating. It turned me off. I'm about to be blunt about this. Listen, I'm about to be blunt. It's all about the mighty dollars. That you get like $8,000, $9,000 per child. If I'm hard on that child, if I'm hard on that parent, they're gonna leave that school district.
Yeah.
But I'm looking at it from a mental health standpoint, not from a administrative point of view.
Yes.
It's more from a mental health point of view. And I don't care about losing these dollars. I'm trying to save this child's life.
Absolutely.
And you worrying about $8,000 or $9,000 per child. This child and this child's parent, you heard me say parent, not parents. Parent is not doing the right thing that he or she needs to do. As me, I'm trying to help the community. Community schools, it means the whole entire community. It's not just the school system. You get, does that make sense when I say that? Yeah. It's a community school system.
Yeah.
It's not the principal school system or the superintendent school system.
Yeah.
It's the community school system. And I'm here from my heart trying to help these kids, and the parents are neglecting them. And it was driving me nuts. They did not understand to care, or didn't know what the first thing to do, or you better kick my kid out the school system, or like you said earlier, you better lock my kid up in a mental institution. And so I'm going to deny everything to keep my kids safe.
I think that's a big part of it. I mean, and then also you have some people believe in holistic medicine. I mean, there's, the medicine piece is a factor. It's just, I mean, look at it. I remember my granddaddy and them, they would work every day. They were sharecroppers. So we're not too many generations removed from people being afraid to lose their job. So they didn't really take time off to do this and to do that. And they were afraid of using their insurance, all kind of things that you wouldn't even think of. So some of that stuff is still lingering in the culture. This thing where we're not fully buying into personal care, health, dental, medical, mental health. And as males especially, we have a tendency, even when we have more wealth, to be negligent of our self-care needs. So until we become more enlightened and more in tune with ourselves, we will continue to ignore some things that aren't as tangibly obvious as a need. We may even bookmark it. We may even label it as a want. Like therapy is like putting my kid in an after-school program, Well, wait a minute. Therapy is not equivalent to, no, don't get me wrong. After-school program can be therapeutic. Yes. But there's certain challenges that children face that an after-school, and I run an after-school program, cannot, we're not designed and trained to have an arts-based program, but it's not designed to work with a child that may have psychosis.
Or chronic depression. or chronic ODD and ADHD.
But it could help. Now, it could help.
Right, right.
It could help. And that points back to therapy. In this sense, we don't really know the different kinds of therapy that is out here, too. We don't know about art therapy. We don't know about DBT, trauma therapy. We just know a general. And then what I see a lot of times, I'll talk to a lot of parents and they'll say, I'm just looking for a black male therapist. And it's such a shortage of, yeah.
It's sad. My son was in college, and forgive me, son, I'm sharing your business right now. But hey, I love my son because listen, he's that guy. Yes. He's very sure of himself, and he was going through he entered his second year of college, and he was really adjustment. He was adjusting to this new life away from home, and he went through a deep depression. And he was like, "Dad, can I talk to you?" I'm like, "Yeah, you know." His mom was saying like something is wrong. Something is wrong. So I'm talking to my son, and he said, "Dad, I'm just down, no energy. I don't care. I worry about my future a lot." He was just pouring out to me. Immediately, I said, "I gotta find you a therapist." Immediately I started. He was at Ball State University, and I'm looking in that Indianapolis, Muncie, Indiana area. Could not find not one black. He wanted a black male, and I could not. I searched all over. I couldn't find one. I couldn't find one. And I told my son, I said, "At this point, son, you need to talk to someone. Please, just talk to someone." And he found a nice young white lady, and she really did a wonderful job with him. Yeah. So I advocate for therapists. Yes. Because I was in my dark world, and I was in college, and I really needed someone to talk to, and I didn't have it.
Yeah.
I didn't have it.
And I guess that goes back to misinformation, not really understanding the skills that practitioners hold that go beyond color, religion, sexual orientation, political background. Sometimes we can stay stuck in those things and assume that people don't have the kind of sensitivity, awareness, and sometimes that's true, but it's not always true.
I know you work for the social welfare. Am I saying that right? Social welfare system for the state of Michigan. Okay. Resources for parents who need support for their children to get their children the right treatment they need. And for the parents. Okay, if I take a child in, I don't work with children anymore. When I take a child in, you best believe I'm gonna work with that parent too. I tell this parent, before I take this child, you're gonna come in too.
Absolutely.
Because I have to educate you on what's going on. There's gonna be more of a family therapy with you and the dad, and I'm gonna do individual therapy with the child.
I think that's very important, and I'm going to answer your question. But that was such an important thing that you said, because I was just thinking about like one of the key tactics in getting buy-in from parents, I believe, is having them involved in the therapeutic process. So getting them initially orienting them to the therapeutic process. And that's what I love working with you. We meet with the parents first. We talk to the parents. And then I would have the parents, because the parents come and they're in the lobby, and I'll say, come on in, let's talk a little bit. And then if I'd have time, I would talk to them afterwards. But there was I believe in having some kind of communication thread between myself and the parent, of course, if the child agrees for that to occur. Right. Because it's us working, it's a collective effort. Now, going back to the resources, we have Parent Care Network. I think that's one. Detroit Wayne Health Integrated Network.
The children of today is the future.
Absolutely.
It's the tomorrow. And people don't, that's why I pour so much energy into children, because I'm gonna be 80, 90 years old one day. and little Johnny, I helped back at, in middle school. I saw this kid. It's funny, I'm gonna share this quick story. I went to the mall, Christmas shopping. It was like 3 or 4, before the pandemic. And this big kid, like 6'6", like, Red. They call me Mr. Red. They used to call me Mr. Red in the school system. And he was coming towards me fast. And you know that fight or flight, I didn't know what to do because this big kid was coming at me. And he grabbed me. You saved my life. You saved my life. And I came in contact with this kid when he was like 6th, 7th grade. And he said, you don't remember me? No, I don't remember you. Who are you? He was so tall. He stated his name. He said, remember? I said, yeah, he was this tall. He like, thank you so much. You saved my life. And that's the reason why I love working with children. But I'm hoping more young therapists come in to, I feel like I'm more like to work with adults now. And I work with children. Some children, they request me. I want to work with them. But I'm getting older now. And sometimes I feel like it might be a disconnect. That's how I feel. Do you ever feel that way? We got over 25 years of experience in this. If you think about it.
Well, the thing about it for me is that was the reason why I went into social work. So it's a little different. It's almost like my mission statement. I mean, but to say that I'm sure there are some things that I'm not fully in connection with young people, but I still enjoy working with young people. I find myself, I don't know what it is about them. They're still receptive. I mean, it's a little harder because an adult kind of has more of an understanding about what their problem is. So in one sense, it's a little harder, trying to crack the egg open with children. But once you crack the egg open, there's yolk all over the plate. And so I really like working with kids. I do. I must admit. And
I love kids. But you said to me, adults are harder. I would tell you why.
You say the adults are harder? Okay. All right.
Especially when they have a personality disorder.
Whoa. Because they got the brain power.
They don't see themselves.
Oh, yeah.
They don't see their dysfunction. It's everybody else's fault. It's not my fault.
Yeah.
It's my husband's fault. It's my boyfriend's fault. It's my mama's fault.
Yeah.
They messing with me. But what are you doing? Let's talk about you. And when you start talking about them, they have this especially narcissistic personality disorder people, diagnosed, I can't say people, but people who suffer from narcissistic personality disorder, they have this high self-esteem, this inflated self-esteem. It's not my fault. Or somebody with borderline personality disorder. See, I tried to work with people with personality disorder. I was burnt out. And this one psychiatrist told me, Dr. Parks, he said, don't do it. Don't do it. And he was in his 70s when he told me, he said, don't do it. It's too much energy. They have to go to a specialist. Don't do it. And I didn't listen to him. I still dived into it. I could do this. And no, it's a lot of work. It's a lot of work. Yeah. They're not ready for treatment. They don't see themselves. Doc, you don't know what you're talking about. Yeah. And all this, it's like a hidden personality. They don't want to be exposed. Don't expose me. Okay, it feels uncomfortable. Go ahead.
To me, that kind of ties into some of the challenges we may face getting buy-in from parents. Some of them have mental health disorders that are diagnosed or not, undiagnosed. Right. And they may, it may be an impediment. As you said, they may be oppositional, or they may be bipolar, or they may be, and then when they see it in their child, they may start defending it. Or because they have this disorder, they may not know how to work around it in order to hear and see what they need to hear and see to be able to help their children.
Right. And let's go back to the DSM-5. Let me clarify this with the viewers. DSM-5, diagnostic and statistically manual for mental and brain disorder. It's a manual for mental and a brain disorder that neurologists, psychiatrists, psychologists, clinical social workers, we all use a psych nurse practitioner to diagnose a mental disorder. And that's our tool that we need. And the ICD-10 is the codes that we use from the ICD-10 book, the codes that we use so the insurance company could reimburse us for our services and our work. So this is clinical stuff that we are talking about, and we are very experienced mental health providers with over 25 years. Both of us have over 25 years of experience.
Absolutely.
In mental health.
So I think what you're saying is very important. Like, when you get a car fixed in the hood, so to speak, they called it the shade tree mechanic.
Yeah.
So he's kind of, or she is somewhere in there. They're not referring to a manual to do this work.
Right.
They've observed things. They're filling it out, right, and they can be good at it.
Yes.
I'm not saying that.
Right.
But as time has evolved, we have more and more tools, such as in mental health practice, we have the DSM manual that we can refer to. That's the Bible of mental health. So when we are working with children and adults, we're not the shade tree. We can't even build. We can't practice freestyling. We have to be able to justify this diagnosis. It has to correspond with something that is coded. And the symptoms and the treatment modality that we're using, everything has to coincide. That's the word.
And the treatment plan must coincide with the diagnosis.
Correct. So this is not shade tree. So I think back to information, a lot of times we don't really know what is a social worker, what is a therapist? Because going back to you, social economics, the more we become socially, and socially is things such as self-care, such as one of which is under self-care is mental health. Economically is we have enough money to have good insurance to access this service, specialized services, to drive to locales that may be able to provide us something that is unique to our child. One of the challenges that I see working in the foster care division, we have, and this ties into what you've done, we have children, they're in a school setting, they're having behavior problems that are just above and beyond. They have an IEP, they're in a classroom setting. The IEP says, no, we don't want them separated over here in this building like when you and I were kids. We are trying to create an inclusive environment, which is a great concept. But the truth of the matter is there's one teacher teaching 40 kids, and they're supposed to individualize the treatment for this, the education for this particular kid. That is a very, very difficult thing to do.
Very difficult. And I heard teachers complain about it, and I totally agree with them. I understand it's hard. I understand all of this is hard. But what about this child? What are we going to do with this child?
I wanted to go back to what I was, social economics, when I was talking about this thing about these kids. I was working at Methodist Children's Home Society, and I was working with children who exhibit the same behaviors, emotionally impaired children. Because children who are in residential group homes, they are children that are in foster care. So when the children are in foster care, there's different settings we can place them in. We can place them with, ideally, of course, their parent, while their parent works to rectify the situations that brought the children into care. We can place them with a relative, which is what we typically do. We can place them in a foster home. And what we try not to do is place them in a residential setting, right? Well, these kids are in a residential setting. So these are the same kids that I'm working with, unbeknownst to me, because initially I started working in residential. Right. I didn't really understand like fully the connection until I started working foster care. Right. Anyway, these kids are exhibiting the same behaviors that these kids I have on my foster care caseload are exhibiting. But they're going to DPS schools with one teacher, 40 kids that are at risk, and they have different things going on too. These kids in this environment, they're going to a specialized school that has a curriculum and an environment that is IEP. The environment is IEP.
IEP, individual educational plan.
They have behavior specialists in the classroom. They have half a days for the students. What an IEP is supposed to do is make special accommodations for the child. But that's where money comes into play. Money comes into play because now I can put my child in a setting that has a 1-to-8 ratio. It costs more money to privatize things. You have to have money to put your child in a private setting versus a public setting. So that's where it hurts. And so now you got all these kids crunched in this environment, and now they're doing X, Y, and Z, and some of those behaviors manifest into other things.
I'm a psychologist, and I test and measure kids every day, all day. I'm like, hey, you can't even teach 40. You have 40 kids in your class, 38 kids in your classroom. You teaching to the top, they call it, you teaching to the middle. The top 10% and the bottom 10% always gonna lose out. You teaching to the middle. So the kid who is a stellar in school is actually missing a lot of educational gains because you teaching to the middle. The kids at the bottom.
So the kids at the top tier, they're bored.
They bored.
That's how I was.
They're gonna start acting out a little bit, you know, because I'm way up here and come on, you guys catch up with me. The kids at the bottom don't know, they don't have a clue what's going on. Yeah. You only teach to the middle because they have to pass what they call it, the educational standards, the testing. You have to meet these.
Is it more kids in the middle for the numbers game?
Well, according to research, you know I'm a fact-driven person, that the top 10% and the bottom 10% always loses out in a public education. And I put my son in a private school in advanced placement classes on like 6-7 kids in that classroom.
I love it.
Because I'm targeting what I want to target, right? I wish my parents could have did that for me, but they couldn't. You know, I understand. But I understand the teachers. I understand the social welfare system. I understand the educational system. And I understand the parental the issues with the parents. But what about the kids? What about the kids? And that's where I'm at. What about the kids? And that's why I needed you on this podcast show, because we must break down this stigma. Parents, you must unmask your own fears, as you say.
Yeah.
You fearing this mental health, and you have two African American guys sitting here, very astute in the mental health, is educating the world that it's okay. Let your guards down, stay focused, it's okay. Let the professional do their work, because I'm not going to my foot doctor for my heart.
Man.
I ain't doing that. Nor I'm not going to my family doctor for mental health. Right. I'm not doing that. I'm going to a psychiatrist, or I'm gonna go to a neurologist or a psychologist, because they specialize. We specialize in the brain. That's what we do. We specialize in different systems. That's what we do.
You know what came to my mind as I'm listening to you? It reminded me of something I was thinking about. How can I get the African American community to become more informed voters? This reminds me of that in a sense. How can we get disenfranchised people, underserved people, that's the word, that's the term. How can we get underserved people to become more involved in mental health services? So when I was doing this, I was like, well, I remember my buddy, he said, when you're trying to teach someone something, you pretty much have to, like you said, you have to speak. It can't be too abstract, gray.
Right.
It has to be packaged a certain kind of way.
And that's where I struggle. I want to use certain words on this podcast show, but I'm sure that you do too, but we can't because they won't understand us. So we got to keep it at a level so that we all can understand. And it's difficult for me sometimes to speak because I'm speaking at a high statistical level, high vocabulary. So I had to bring it down so people can understand what we are talking about. Absolutely. And this is deep. I'm happy that you came on this show because out of all people, Mr. Robert Mitchell, the philosopher I call you, will understand how to deliver this message without attacking parents.
Yeah.
Just making sure they understand the stigma that they carry, fearing for their children to get the right help that they need for their mental health.
Absolutely.
Right? So we're going to end this show. And listen, Robert, Mr. Mitchell, Mr. Philosopher, I appreciate you coming on this show. I appreciate you helping me break it down the stigma so people can understand what is actually just going on in the community and with parents, with their behaviors, how they impact their children suffering from mental health disorder. Thank you for coming. Denial may shield parents from the truth, but it also blinds them to the opportunity to support and help their children's mental health. Thank you, viewers. I appreciate you. I will see you next week. Until then, take good care of yourself.